Okay, so we're starting with how this disease gets transmitted. This disease, COVID-19, is transmitted by two ways of transmission. Droplet, that is a spit, that is sneezing, or that is cough, that goes in a parabolic way and it tries to reach the other person or whoever is in front, or just because they are sneezing or coughing or vomiting. 3 to 4 feet. We need to, that's why our first line of protection is distancing. We need to do 6 feet distancing. If she's a patient and I identify as a patient or as a possible patient, I need 6 feet of distancing and I stay there. If that patient gets towards me, I keep my distance. No PPE, I keep my distance. I'm safe. She keeps going and I keep my distance, 6 feet. This is your first line of protection, okay? Distancing. She doesn't have a mask, I don't have a mask. This is you're protected there because she's not gonna get you. This is not an airborne disease. This is droplet. So that's our first line of protection, our distancing. When I identify that she is a patient that is potentially having COVID-19, or that somebody tells me, hey, she tested positive and she's not, the first thing I'm gonna do, I'm gonna protect myself with the 50% of my piece, which is a mask. I place a mask, and then I got all my contact isolation. My contact isolation will be, hand hygiene, obviously, gloves, mask, eye protection, and gowns, okay? That's how I'm gonna gear up. Now that I have this, I'm gonna, my droplet 50%, I need the other 50%. I grab a level 2 surgical mask and I give it to the patient. I have mine here, so now I'm gonna have mine 50%, and now she has the other 50%, So, at that time, we are protected on the droplet, and I'm protected with my gown, my gloves, and my eye protection, okay? That's used for a patient that is under the investigation and it is non-ventilated, invasive ventilation or non-invasive ventilation. What is non-invasive ventilation procedures? Procedures are non-ventilated, intubating a patient. That person that is intubating the patient needs to have an N95. If we are in a mechanical ventilation, that patient needs to be on N95. If we are aspirating a patient constantly, that provider or healthcare provider needs an N95. If a patient have a BiPAP, N95. If you have high nasal flow, N95. So that is called extreme isolation. Extreme isolation, again, hand hygiene, gloves, respirator, N95, okay? Gowns, and wear a surgical mask over the N95. Why? Because we will need to reuse those N95s up to 5 encounters. Put it in a bag, paper bag, either carry it with you or put it in a safe place in a paper bag. We're gonna start getting the paper bag out. Okay? But for any other, situation that is not any of the ones that I have mentioned, ventilated, invasive ventilation, non-invasive ventilation, or aspiration, because in that moment, even though it's a droplet, you can aerolize the surrounding of the patient. When you are doing the difference in between airborne room and droplet room, the droplet room is a normal room. A regular airborne room for tuberculosis is a negative pressure room. Disinfection does not need negative pressure room. When I explained that droplet is this, airborne is, if I have tuberculosis, a big cavity, and I have the mycobacteria, and I spit it, you know, and some of it aerosolizes, and the mycobacteria does this. Instead of going in parabolic, it does this. And then somebody passes by, you know, like the Forrest Gump with the feather, you know, that it's trying to go down, and then somebody passes by and it goes up again. And then it goes all the way up, and it continues to be there. Okay? That in tuberculosis, we need a sucking machine that gets the negative pressure and pulls the air and it has a big, that extractor has a big N95 to filter. Well, not this situation. This situation doesn't necessarily need that. Why? Because this virus doesn't stay in the air. If we would be in New Mexico, maybe it's dry as hell, you know, but not in that situation, okay? I forgot we were in this, huh? So this is not a situation. This situation is a droplet. But when we are aspirating or on those mechanical ventilation patient is there in the bed, and I opened the door and I said, your test for flu was negative. Social, the distance of 6 feet, you can open the door. This, you see this? You can open the door and say to the patient, your test came negative, or call. There is no problem opening the door and talking to the patient at 6 feet. No, you're safe there. So you can do that if you want, if you want to look at if you need to do that.
How about the concern like the droplets will survive in surfaces?
It will.
It will.
It will survive.
Even at 6 feet, like if they, as long as they didn't touch the door or.
Well, I mean, if you are, you have to wash your hands. You know, if you open the door from the outside, you will need to wash your hands because you touch a metallic surface. But if you open the door and you're at 6 feet, you can talk to the patient. Now, the patient should have 50%, right? The 50% is the patient should use a mask. Do you feel more comfortable using a mask in that situation at 6 feet? You're wasting one mask in that case. You just open the door and say, hey, I got your result from hepatitis, it's negative. You want to do it over the phone? If the patient is able to pick up the phone, do it over the phone. But let's reduce the entrance to the. I noticed yesterday that, for different situations, they were getting into the room. So I'm learning now. That's why we're going at 1,200 per day of gowns and of masks.
And so recycling is just for N95.
Recycling for N95, that's the only reason why this extreme says wear surgical mask over N95 is just to protect it from the droplet, because of if the patient spits at you, cough or sneeze, and that particle comes into the N95, at the time that you take your N95, if you don't do it properly, you will touch that and you have the fomite in your hand. But if you have the surgical mask over the N95, you can use that N95 for 5 encounters. After 5 encounters, when you're moving it, it doesn't work at 100%. It may work. My good friend, Dr. Latterbach in Michigan, sent me a picture. His hospital doesn't have N95. We do. We just got a shipment 2-3 days ago, and we have thousands of N95s. They don't. So, and I'll share it with you. He's putting Lysol on his N95. That's in the level that this is my friend. He's this tall, Latterbach. He was one of my residents. He's a hospitalist now. He is using Lysol. We cannot get to that situation. We have more resources and we have more time than anybody else because there's no spread in the community right now as much as we thought that it could be. Okay, so let's protect. This is not anymore part of the hospital PPE. This is our PPE, or from any one of each of you and me, because this PPE now is for us. If we don't use it well or we don't protect it, we will suffer at the end because we won't have PPE. It's going like crazy. So overnight, I told the lab, I don't want you to wait from 5 p.m. to 6 a.m. to notify that the patient is negative. Every hour counts. If it is negative, out of the PPE. You know, if it is positive, send it to the OIC.
One negative is a confirmed negative?
Yes, sir. At this point, there's nothing else we can do. Everybody asked me about the sensitivity and specificity of the test. Nobody knows or nobody wants to release it. Can we do anything about it? Can we do anything about the sensitivity? This is a state of emergency. Can we do anything about the fact that we do not know the sensitivity of the specificity? We can change it. We cannot change it. It's the same. Oh, let's repeat it. When you repeat a test, you do not change sensitivity or specificity. The only thing that you're testing there is accuracy. And accuracy is for the FDA to test, not for us. If the FDA approves those tests, the accuracy has to be good. We cannot make assumptions in what we cannot control. But you know what we can control? We can control this, that we don't run out. We can control getting patients out. We can control using our brains to see, no, this patient really doesn't need to be tested. We can control what we have in our hands. We cannot control what is not in our hands. There's no supplies for testing. There's no supplies for testing. What are we going to do? We can't do anything. We have to do what we have in our hands. And what we can have in our hands is, oh, I can ask the lab to put another shift person to be fetching the results to see at what moment it turns negative or positive. In that moment negative, call here the patient out of this unit. You know, we save PPE. That's what we can do. If we can save the patient home, we will save PPE. If anything that it is in your hands to help, I will appreciate it. You're the first line. You know, this is a droplet and for my infection. This is for special isolation, is for patients under the investigation that are non-ventilated, either invasive ventilation or non-invasive ventilation. This is for positive patient, extreme isolation is for positive patients for COVID-19 or that are ventilated, invasive or non-invasive, plus aspiration. Yes?
I got a question, like over the weekend, they had tested multiple people for COVID. How do we handle that on the weekend? Is the ER the first?
I guess I read somewhere about of trying to avoid nebulizers as much as
So-
possible.
Any patient that is under investigation, currently, if they're on nebulizers, we have changed them to
NDI.
inhalers. But those, as you can imagine, are on shortage and hard to get now because of the pandemic. So, again, need to treat the patient, but if there are those that don't have to have it, then, we will give them as long as we have them. And when we can't
So which one? What's
albuterol.
Yeah,
Yeah,
the
okay.
inhaler. So,
Okay.
but I was asked that question a week ago about the nebulizations, okay? I went to read from the infection prevention, and I can share the document. Nebulizations are not aerosolization procedures. It's really good that we have changed to that, but even though I put it in the interim guidelines that you may have received and it says nebulization, I went to review it again, and nebulization is not considered aerosolization NIPPV. We may get different opinions on different places, but the latest I read yesterday or the day after yesterday, nebulization is not. Either way, we are using MDIs.